Hello, and thank you for joining us um, for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Advance Directives, POLST, and Dementia Directives. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. So this workshop is kind of a part two, a deeper dive into the forms. And Karen was so gracious enough to provide a workshop on end-of-life options general overview last week. So that workshop was recorded. So if there's anything about end-of-life options, if you haven't seen the recording or haven't attended the workshop, you can find the recording available on your Sunday program email. If you scroll to the bottom, there's a section called Recent Workshop Recordings, and you'll find that link there. So I wanted to make sure you knew about that. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any questions into this chat function found at the bottom of the Zoom window, and then we will find appropriate times to ask those questions. Without further ado, I'd like to introduce our workshop speaker. Karen Morin is a seasoned oncology and hospice nurse with extensive experience in medical aid and dying MAID. She founded LA Patient Advocates, an RN-led patient advocacy practice that partners with hospices and referring physicians to guide patients and families through the complexities of serious illness and end-of-life decision-making. Thank you so much, Karen, for being here with us today.
Thank you. I always love coming and working with your community. So there's a lot of information here, and I think a lot of you may already be, well, there's the first glitch here, come on, familiar with some of these forms. And so let's take a little time though. I think sometimes we finish them up because we're supposed to be finished with them, and we don't really want to be dealing with them at all. So someone had asked the other day, like, what does half of this medical stuff really mean? And can you explain some of it? So here's our basic, we're trying with all these forms to translate what our wishes, what our desires are. So when it gets to end of life, we're going to be able to get what we want, how we want to die, where we want to die. And basically, these forms are helping to spell that out for our loved ones, for our doctors, for all of those who care so deeply about us. And we know that these discussions are important, but we also know that few people are actually taking the time to have these real discussions. We sort of dance around them sometimes. So at least if we put it in writing, we will know then that, hey, it's in this place and we can access it. And now with these particular forms we're talking about, there's some real legality to it. Whether or not they always get followed when they're read by the medical profession, that's another story. And we'll talk about that a little bit. But we plan for births, we plan for weddings, we plan for college, but we really need to plan and prepare for our deaths also. So the Advanced Healthcare Directive, and there are many forms. What I usually end up doing is Googling the California Advanced Healthcare Directive. And there's a couple of them that are all perfectly legal. There's one that's has a little more pictures on it if you have more difficulty with that, or you're working with someone who maybe doesn't have a higher reading level. We still want to be able to impart the same information. But it it involves giving clarity to those that are going to have to make decisions for us. And remember, these documents work when we're not able to speak for yourselves. So at any time you're in the hospital, a decision needs to get made, they're going to go to you and say, look, we can go with choice A, B, or C, which do you prefer? But if you're not able to speak for yourself, who is then going to be that designated person to speak up, going, oh, I know what she wants, and we've talked about it. Let me speak for her in this situation. So someone who is 18 or over with chronic illnesses, maybe a couple of underlying diseases, they should have advance directives. If you have someone, a family member with disabilities, or you just want to make your wishes known to your family and your doctor. This is also going to be a document that is a process. It's not one and done. I always tell people, come back to it each year, look it over, see if you've changed in any way. Have you changed? Have your feelings about things changed? And even though it's all been done, you can always sign it and date it. I've reread this and I really stand behind everything in this document. Initial it and say, let's keep this in place. So it's not important to make choices about every intervention, but it's kind of a ongoing document. So you start out in the beginning. I mean, I think I'd go here in the beginning. Who's going to speak for you? Then that's the first decision you have to make, is who's going to be your power of attorney for healthcare if you can't do it. So I've seen everything from a relative to a neighbor to someone in another state. You know, now since COVID and FaceTime and the use of computers and texting, it doesn't have to be someone who's close to you in proximity in terms of a neighbor, but it really does make a difference. But more importantly, you want someone who knows and understands what you want and what you don't want, and someone who you know will speak up. You know, you don't want your most timid of friends, and someone who's not afraid to ask questions and be sure that you are going to get exactly what you want. And so it's asking for a lot of information about this person, address, phone numbers. You know, I would also put the email information in, and you want to have a backup in case that person isn't available. So there's a room on the first page for not only the agent you're choosing, but a backup if they're not able to. So my other review these forms every year are the 5 Ds, I call them, that every decade, a death in the family, a divorce, or a change in diagnosis or a decline in a condition. Even if you don't change the healthcare directive, you might want to add some addendums, and we'll talk about those also. So the next page really talks about the agent's obligation. What are you asking this agent to do? To make health decisions for you if you're not able to the best extent of your wishes as they know, okay? That they should always take your best interests. And then there's also a section here about post-death. So your healthcare agent is also authorized to donate your organs, tissues, parts. So make sure there's a few lines in there if you don't want, do want, if you've already made plans. You know, I have a lot of patients lately who've willed their bodies to one of the medical schools or institutions. So all these directives come with a lot of blank lines, and don't be afraid to use them and add what you need and don't want, what's specific for your situation. And this brings us to that conversation that you're going to have both with your doctor and your family, that these kind of decisions don't happen overnight. Recognize it can take multiple conversations with your doctor. Let them know you want to do an end of life discussion, because Medicare will cover an end of life discussion. So make that a separate appointment. Don't combine it with other things that are going on. With your GP, sit down and discuss what you want and don't want at end of life. If there's a new diagnosis, what if I do nothing? And what quality of life will treatment give me? Remember, treatment isn't the same as a cure. So talk those things through with your doctor and make sure you understand exactly what they're proposing and how that will change your quality of life. What can I expect the next year? And where will that leave me in terms of prognosis? And also, when you're talking with your doctor about an upcoming treatment and your advance directive and what it means to you, let them know if there are milestones coming up in terms of weddings, bar bat mitzvahs, things that you want to be sure and be there for. This is the other 5 myths that I need a lawyer. No, you don't need a lawyer, but I think it really helps to get it notarized, even though in California, some of the forms don't require a notary. I think it's worth it to have it notarized so that there isn't any bickering. If you have a family that can contest it. The advance directive should be notarized, but the other documents we're going to talk about don't need to be notarized. It only matters if it's put in writing. Well, if you discuss your wishes with your family, hopefully that is the beginning of setting some plans in motion. I only need a plan if I'm old or ill. No, but we don't know. It doesn't matter age. I lost my husband at 53. Things happen, emergencies happen, car accidents happen. So like I said, I wouldn't wait for the very basic of advanced healthcare forms. And once you put your plans in writing, I can't change them. They can be changed at any time. In fact, you should review them every year. Oh, there's my 5 Ds. If you move states, that's another one too. Okay, so moving on. These are more planning questions. Sometimes people say, well, I don't know what to put, or I'm not sure what I want. So some of these questions are just to help get you to think about your quality, your health condition, what's going on. Or maybe, as a lot of people say, oh, I know this woman and she just went through this terrible thing, and oh, I don't want that to happen. So use those experiences to help formulate your own plan of what you would like at end of life. And if you've had illnesses, what trade-offs are you willing to make? Okay, it is overwhelming, it's difficult. And I think it's going to take setting down a couple times to really get things down the way you want them. And I would, in terms of getting copies of these forms, get more than one and do a little work in pencil before you go, okay? So that on page 3 of the advance directive I'm working on, it talks about instructions for healthcare. Oh, we got more questions here. Patient safety and advocacy, a gift to those who must speak for you. Hey, I can agree with all these things. So there is a lot of benefit for doing this. This is a big one in terms of, oh, I want to maintain my quality of life. Quality of life is so important. It's really a good tag phrase that all of us in end-of-life care use. But it doesn't mean the same to everybody. For some patients, it means being able to go to the Dodger game, to actually get there and go. And for some, it means being able to get down on the floor and play with grandchildren. Figure out what that means, because quality of life changes as we get older. And so don't use any of these phrases, no heroic measures or extraordinary treatments. Hey, a lot of the treatments we're seeing these days can be pretty extraordinary. when we think how we made them and treatments we didn't have a decade ago. And I don't want to be a vegetable. That's one I've heard a lot. Well, you've got to be a little more specific. And I don't mean which vegetable. I mean, what forms of your body are you willing and what you want to be able to do? It's more about what you can do for yourself. And we'll talk about that too. But, you know, what is living well to you? Be specific. Another thing I hear a lot is, my friend had the Advance Directive and nobody paid any attention. And that's true. There's always those stories of people that end up in an ER and, it's an emergency and they do what they do. We'll talk about some other documents to prevent that, but make sure you choose a healthcare proxy who's committed to honoring your wishes. So it's important to discuss it frequently. You could get to be a very boring friend if you're doing it too often, but letting each other know how important it is. And when your wishes change, when your conditions change, make sure it's one of those friends that you're keeping updated. And even if it's not your healthcare proxy, if it's someone you're spending a lot of time with, make sure they at least know where your Advance Directive is or know some of the things on it. If these are people that you're with a lot and something happens and someone is going to call 911 or you don't want them to call 911, you want to make sure that you've clued them in on some of that. So ensure that there's clarity and state preferences. And if you need to exclude unwilling family members, make sure it's written in there. Believe me, I've dealt with every kind of extended family and family issue. And, this is new, but you can always make a video or a short audio recording that says in your own voice, this is what I want and what I don't want. And I think, again, if you have a big family or you feel like somebody might question some of the choices, that's always a very good, strong way. And don't forget to date that video or audio. And in the end, even though I'm sitting here going through all this paperwork with you, and it's very important, oftentimes it's the decisions by people, not documents, that are going to make a difference. Like you say, that emergency in the ER, whoever is with the patient, they're going to be asking a few questions and then they act. But they are going to want to know what the patient wants, what do they not want to happen. And so let's make sure that we have it documented clearly. All right, quality of life. What do you agree? What do you think? If you were so sick, you might die soon. I know that's hard, especially in this community, to think about it. But when we're having difficulty initiating what it is about my quality of life that's important, and this is what changes. What do you want? What would you want them to do? Try all life support treatments, even stay on life support, even if there is little hope. And that would be the ventilator also. As we go through this POLST, and we'll talk a little bit about exactly what each of these means, including feeding tubes. But do a trial of life support treatments, but do not want to stay on if there's little hope of getting better and getting back the life I value. And that has its own issues of taking someone off of life support. But it's better than it used to be in terms of if someone truly is not going to be able to come off the machine. But the idea is not going on a ventilator if you don't want one and you don't think it's going to be of value. Or I do not want life support treatments and I want to focus on being comfortable and wish to have a natural death. Now, those aren't the be all end all of the statements, but I think taken together, it can help to get an understanding of your quality of life. So we're back. Let's look at it step by step. Oh, I jumped right into it, didn't I? Okay, so we've got the part where we've, I knew I was going to get to this advance directive here eventually. So we're giving the name and address of the agent that you've chosen. And I like this one. This is the one that I think that we'd send to you guys that comes from California, because not only it actually has the directions right on the side. You really don't need a lawyer for this one if you're following what they say. And you can have as many backups listed as you would like. This one, I know I got mine covered here a little bit in terms of what you want the, if you want to limit the power of the healthcare agent. And where I find this comes in more, and there's more rooms at the end, is when it comes to feeding. And I guess, I know I talked about this in other places, we might talk about that. Because I know on mine, this is where I wrote, you know, in terms of artificial hydration, nutrition, and other forms of healthcare to keep you alive. One of the things I wrote here is I don't want to be spoon-fed. If there's a certain point where I can't eat and I don't want to, I need to be spoon-fed and I'm not turning my head towards food. We'll talk about that a little bit with Dementia Directive, and you'll see a lot of these overlap. But this is an area where you can be very specific if you don't want to be spoon-fed, if you don't want feeding tubes, but as long as I can feed myself, that's great. If I'm not feeding myself, then I don't want any nutrition. So, and if anyone has questions about, I just jumped back, about any of these after this, let me know. And if you're having trouble getting what you want down on paper, I'm glad to talk with you. When is this going to become effective? Usually we say immediately. You have to check that box if you want it to be immediate, or say you're getting ready to go in for surgery and you want to put the surgery date up until the date you end it, something like that. So the second part, the agent's obligation, that to the extent my wishes are unknown, my agent shall make healthcare decisions for me in accordance with what I've determined to be my best interests. So whatever they think are your best interests based on your conversation, my agent shall consider my personal values to the extent known by the agent. I know they tried to not do so much legalese, but, and then again, here's the area about disposing of the body. If you want to have your eyes donated or any other body parts, or you want to will your body, number 5 is the place where you should add it. And then a conservator, if my person needs to be appointed for me by court, I nominate the agent designated. This is if you already have a conservator. All right, some of these, okay. And then in this part of the form, you can, and any of these forms, it says you can strike any wording you do not want. And any of these forms you're filling out, if there's things that you don't want, cross it out and initial near it. So when you're done with these forms, you've got them exactly the way you want it and what makes the most sense for you. I'm sorry, these are all jumping around. So I direct my healthcare providers and others in my care to withhold or withdraw treatment in accordance with the choices I've marked below. And on this page, they only want you to mark one box, excuse me. I chose not to prolong life if I have an incurable, irreversible condition that results in death within a short time, and I'm unconscious to a reasonable degree of medical certainty, and I will not regain consciousness, and the likely risks and burdens of treatment would outweigh the expected benefits. And there's still a little room under there if there's something else you want to write within that choice not to prolong life. And then B choice is choice to prolong. I want my life to be prolonged as long as possible within the limits of generally accepted healthcare standards. Okay. And then we talk about relief from pain. Except as I state in the following space, I direct that treatment for alleviation of pain or discomfort should be provided at all times, even if it hastens my death. And this is where I always say a little bit about pain management. I work with a lot of, almost all terminal patients right now, and I hear every day, multiple times, well, I didn't want to take the pain meds because I didn't want the side effects, or I don't want to get addicted, or whatever other reason there is. And if you're at your end of life or terminal, or if you've already been told you have a shortened lifespan because of your condition, by all means, take the pain meds. You're not going to get addicted if you're taking pain meds for true pain and not for a psychological reason. Take the pain meds to alleviate the pain. Take them on a regular basis. And, as soon as the pain starts to wear off and is starting to come back again, then take the next dose. The biggest part of maintaining a quality of life is getting relief from pain. And I know it can be frightening sometimes with some of these drugs, and morphine, I hear so many people are afraid of, but it is the one drug that is so close to our natural endorphins. It works extremely well on 99% of the patients, and it is metabolized really well, so we can go up to really high doses for people that are having really, really struggling. But there's so many different medications. So please, please, please use the pain meds and find a system that works for you. And the side effects, it's easier to deal with the side effects of opioids than it is to, have someone in pain and deal with the consequences of pain. If someone gets constipated, we have a myriad of drugs that we can use for constipation. If there's nausea, there's great medications now for nausea. When I first started doing oncology and bone marrow transplant, Zofran was just coming out. And for the first time, we had medications that were really helping that chemo nausea that we saw so much of. And if you don't agree with any of the choices, it gives you a whole page to write in some of the other wishes you might have or instructions you have. So you can do other healthcare wishes. You could speak about hospice or other advanced planning, or even burial information if you've already made plans, anything. So there's plenty of space here. This is about donation of organs, transplant therapy, research, or education. Or if you're not giving anything, you can just cross off the whole thing. But I like how this is laid out. And it doesn't mean that if it's not filled out that you wouldn't donate them or you couldn't at a later time. Strike through anything you do not agree to. So if there's definitely not something you're interested in, make sure you just cross it all off. And this is for your physician, just to have the name of your primary and a second physician. And what's good to know about this, a copy of this is the same effect as the original. Okay. So if you choose to sign with witnesses, you can't use your healthcare provider, it can't be a witness. If you're in a board and care or an assisted living, the operators or owners can't be one of the signatures. you can use a notary if you decided to have your signature notarized. If you are in a skilled nursing facility when you execute it, one of your witnesses must be a patient advocate or ombudsman. Okay. And then there's other pages that talk about who the witnesses are. They just want to make sure that anyone who's filling this out, that no one else has anything to be gained because you've selected certain choices throughout here. Now, you see how this one has a lot of blue lines, because a lot of these you can download right from the internet and fill them on online, but that's difficult for a lot of places to do that way. And and then if you do use the notary public, they fill out this last one. So I did try to get all the pages. Sometimes we do this, and so a little bit about CPR, just because a lot of these forms ask, do you want CPR? Do you not want CPR? And I have to say, I have these slides. A lot of it had to do with how on TV, 90% of the people have CPR, they get a breathing tube, and 20 minutes later, they're all talking. When in reality, that survival rate is not nearly that high. It's really about 18% reality. And I have, this talks a little bit about when it is most effective and when it's not. And just last month, my 50-year-old nephew, who's an ER doc, ended up coding in his own hospital, and they did quite a few rounds of CPR and had to shock him, but he lived and he got discharged. So when you have no one person like that, your statistics get thrown a little bit. But so this just a little bit of a deeper dive on CPR so we can understand it. So we're going to talk a little bit next about the POLST. So if a patient wants death with dignity or choosing do not resuscitate, it's not a matter of giving up, but choosing a peaceful and natural death. But remember, a lot of people, when they do a natural death versus CPR and trying to bring people back that way, that's only going to happen if it's a sudden cardiac event. If you have documents in place that saying you don't want to be resuscitated or I don't want CPR. So let's look, I'm not going to go through all these, but this talks about how often CPR is effective, whether we're doing shockable rhythms or a bystander comes along someone. So it's important to know and understand that the percentages are low, but it's like with anything else. If you're the one in that percentage, then it's an important factor. So I think by and by, you have to take into account your condition. If you have cardiac issues or whether you don't, as you're looking at some of these forms and deciding whether you want CPR to be attempted or not. If you have advanced cancer, this I think is the money chart right here. Whether you're a healthy adult with a sudden heart issue or someone with advanced cancer, end-stage heart disease, or a severe infection, when is that CPR going to be successful and when isn't it? And that's, my friends, why we have doctors making these decisions. So let's look at the POLST because,
Erin,
yeah.
Before we go on to that, there was a question, where do we get the form that you're reviewing? So for those who registered, you should have gotten an email from me that has the PDF of all three forms, the Advance Directive, POLST, and Dementia Directives. If you look in the Zoom chat, I am also uploading them as well. So there is a little box with a down arrow. So if you click on that, that will download it onto your device and you're able to have the copy of that. And then for the POLST question, she's going to be reviewing it now. So
Oh, sorry. Yeah, I haven't been looking at the chat either.
no, I'm doing that for you, Karen. So I just
Okay.
want to make
All
sure
right.
everyone knew that I was posting it into the chat if they didn't see my email. Thank you.
Okay. All right. Great. No, I understand. Okay, now we got to move forward here. Okay. Now it's jumping back and forth. Come on. Okay. So the POLST form is a pink form. I think the one I have here is not pink, but and it doesn't matter what color it is, but I like when they come pink because it's a bright color. It's meant to be filled out by your physician with you together. So remember we talked about that end of life discussion having with your doctor? That's a perfect time to say, look, I think I need a pulse and I want to fill it out together. So it's physician's orders for life-sustaining treatment. That's POLST. In other states, if you're in New York, it's called the MOLST, MOLST, or MOST. So you can see it's different in other states. But the fact that this is filled out kind of like when the doctor makes an order in a hospital, I'm recommending this for my patient. And then he signs it. It means that if the ambulance comes to your house, they're going to look around, and if they see a pink form hanging on your refrigerator or near your door, they're going to grab that because that is the physician's order, and it's more of a legally binding statement than anything else we have going right now. So there's a number of organizations that work quite a while to get these standardized and getting the medical establishment honoring them. So people with a terminal or advanced disease or chronic disease, patients with dementia, people who are frail or elderly, and always those in the hospice or a skilled nursing facility, and those who decided that they do not want to be resuscitated should have POLST, physician's orders for life-sustaining treatment. And if you have your form there, if we look at the, did I jump there? Oh, that's the same with it in. And I always say they will honor, something's going to happen in every ER that might not, but then you're going to have your advocate there speaking up going, look, we got our POLST, this is what we want. Oh, there you see how pink it is. It applies in emergency, unlike the healthcare Advanced Healthcare Directive. The pink one will work in an emergency. No one's going to go all the way through your health directive and go, oh yeah, what did she say she wanted in this? But the great thing about the POLST is it's all together on one form, and it's very easy for the staff in an ER to look at it and go, oh, okay, this is what we want to do. This is what we don't want to do. And so all those conditions, or we like to say, if in the next 12 months, the patient were to die, and it wouldn't be a surprise from the clinicians, if you get resistance from your doctor about filling it out, you can say that, but generally. So the first box is about CPR, cardiopulmonary resuscitation. And that's when someone does not have a pulse and is not breathing on their own. Okay, do we want to attempt resuscitation, CPR, or do not attempt resuscitation, allow for a natural death? So you have to choose one of those. And it requires full treatment. So we're going to look at part B first. So don't be checking anything off until you've read the whole document and understand it, okay? So if you found without a pulse, not breathing, full treatment is prolonging life by all medical means. additional treatment described in selective and comfort focus. It's kind of like, choose from column A, B, or C, but you're going to get everything that's going to be down below if you're choosing full treatment. Intubation, a breathing tube that goes down your throat. If you watched all the medical programs, we all know how to intubate someone now, right? Advanced airway interventions, mechanical ventilation, and CPR and cardioversion. That's when they do the shock. That's cardioversion. You can also click trial period of full treatment, though I think that has its own issues. And even though, my feeling is if there's blank space and you want to write something in there, go right ahead. Just make sure that it's very legible and it's easy to read. But okay, the next one is selective treatment. The goal of treating medical conditions while avoiding burdensome measures. So in addition to treatment described in comfort focus below, we're going to use medical treatments such as IV antibiotics, IV fluids. They're not going to intubate. They're not going to put the breathing tube down the throat, but they could use other non-invasive, like there are positive pressure breathing machines that actually kind of push the air into the lungs, but they're going to avoid intensive care. So that's selective treatment. And then it's going to ask you, request transfer hospital only if comfort needs cannot be met in current location. So let's look at comfort-focused treatment. The primary goal of comfort is maximizing comfort, relieving pain and suffering with medication by any route as needed. So they're going to go ahead and use oxygen. Oxygen's fine. Suctioning, if there's a lot of fluid in the mouth or throat, manual treatment of any airway obstruction. And then we're not use any treatments listed in full and selected treatment unless consistent with comfort goal. And then again, it's going to say request transfer to hospital only if comfort needs cannot be met in current location. If someone's in so much pain, or we're not able to, I'm trying to think about a couple of other reasons we would transfer these patients. Generally, if you put down comfort-focused treatment only, you're not going to be transferred to the hospital unless someone is really in so much pain and there are no pain medicines there, then we're going to ask about getting you transferred to the hospital. And then there is 2 lines there for additional orders or information that you want to write there. But again, this is something that you're going to discuss with your doctor, and I'm sure they're going to have their own opinions on why you should do certain things and what you wouldn't want to do. So for your condition, I'm trying to think, I've had patients that were on certain medications for a chronic underlying illness. So you might want to make sure that you've included that medication. Why it doesn't, it's not just a pain medication, but it's something for your condition. I'm trying to, my mind is going blank now. I can't think of the name. I thought of it earlier. So, but if there are certain meds that you take routinely that you want to make sure that you continue to take because it's going to help for your comfort, make sure you put those in there. Let's go a little further though and talk about this artificially administered nutrition, because that's a big area that really sets us up for so many other things. Or I guess I did this all over again, didn't I? I'm sorry. I had this all set up so we could see it. So anyone, okay, so we're going to talk about that artificially administered nutrition. Food, offer food by mouth if feasible and desired. So if you long-term artificial nutrition, including feeding tubes, a trial period of artificial nutrition, including feeding tubes, or no artificial means of nutrition. So I think we need to talk a little bit about what that means. and what are some of the complications with that. I'm going to skip ahead a little bit here because there we go. So tube feeding, delivered through a tube into the stomach or the small intestine, an NG tube, one that would go through the nose, but we only keep those in for a very short time. And then a PEG or a J tube are a small surgical procedure that allows feedings that way. Now, IV nutrition is something people think, well, can't they just put an IV in? Well, TPN, that, you know, the IV fluids are just fluids. You can get a little bit of nutrition in there, but there's no real nutrition. If someone who's been in the hospital for a few weeks and needs real nutrition, it's called TPN, and we really need to give it through a really big vein. So that's when the digestive tract can't be used at all for whatever reason. And it's very expensive. You need special nurses to come out. And usually by that point, those patients' veins are giving out. And with any of those ways of getting nutrition, we're going to start talking about discomfort, infections. Definitely you get digestive issues with tube feedings, nausea, vomiting, often diarrhea. And with TPN, you've got to do a lot of blood draws, and because you get spikes in not only sugar, but potassium and magnesium. And other, think about patients who may need to be secured because they have some dementia, they're pulling out tubes, and it really will prolong the dying process if the patient is near the end of life without really improving anything. Those with dementia will have increased agitation, and it can feel a bit unnatural and distressing to the family. So we want to look at what we can do that will help to prolong life, and back to that quality. What is the quality of life that you're looking to achieve? And we want to decrease hospitalization and medical intervention. I know this print is really small, but I think I was just trying to give us all the benefits and risks of artificial nutrition, because it seems to be a very sticky topic sometimes for patients. I think less often for the patients. Patients know they don't want to go on with feedings, and are usually the ones that are more often ready to stop. It's the family that feels like we need to be doing something. Mom is just not eating and she's going to waste away. And we have to remind each other that it's the disease. It's not mom choosing not to eat. Our bodies at end of life start to shut down slowly, sometimes, and sometimes quicker. And there are a lot of consequences. Every part of our body is connected to another part. And everything we do, every medication we take, every intervention we do is going to have an effect, cause and effect, and consequences. So I won't go into all those, but there are issues with each of them. So, someone brought this up the other day in another talk about HIPAA, because, everything's supposed to be kept private, and we've given out this information. Now we're going to hang it on the wall, and then we're going to pass it on to other people. But remember, it's a voluntary form. It doesn't replace the Advance Directive, but it's completed so that we can make sure that the legal decision makers will be able to know exactly what the patient wants, and they're able to get a doctor's signature behind it. Or nurse practitioner or physician assistant can also sign these if they're working under a physician. Oh, this is back to CPR, the other consequences, CPR. Sorry, I got out of it. And I don't think we have to go into this too much about rib fractures and chest injuries and other lung damage. I think we've gone through that subject enough that CPR can be very effective for some patients, and but there can also be times when we have severe side effects to it, including broken ribs and pneumothoraxes and all. So dementia, 1 in 2 older adults now die with or from dementia, and it's the 7th leading cause of death in the United States. So deaths from Alzheimer's has more than doubled. My dates are older here. You can see how long I've been doing these, have decreased. So, and people can live up to 10 years. So one of the things that we have started to work towards is a dementia directive that actually speaks to, hey, if I'm at this stage of dementia, I want this. So, again, a little bit of repetition. So when I was looking for a dementia advance directive to go over, I ended up using the one from Compassionate Choices. And that would be the link that you got from Rebecca. And the important thing is it's also one of those documents that you can fill in the blanks right online, or you can download it. And this is from one of their pages. I work with them. They're a wonderful group that really talks about, they're a big nonprofit that really goes to bat for all of us and what we all want in terms of making choices end of life. So definitely go to their website, check out some of their tools, and they worked in every state to try and get the End of Life Option Act passed, and on dementia addendums. So again, we're going back to when we started talking about dementia and advance directives. It's the same kind of thing, but you can look at all those quality of life things we talked about in the final weeks. But if you have dementia and you're not able to say what you want and what you don't want, I think we're talking about two different kinds of illness. You could have a chronic illness, an infection, or a cancer, and you fill out the POLST, and they're going to have an understanding of what you want and don't want. But if you have dementia, you could live a very long time. And there are a lot of dementia patients who don't have illness or don't get an illness until later on. So what can we do, and how can we express our wishes when we have dementia? So the value of filling these out is, I'm going to jump through here a little bit. Again, if you go to some of the web pages for Compassionate Choices, you can find these documents, but you have copies of them or you've downloaded them already. You know, this was one of their earlier versions of, oh, you're going for a dementia appointment. Maybe you're in the early stages. I don't have it. I'm a caregiver. It was kind of directing you to things that you might want to ask and questions to ask your doctor about dementia, where you are now and what kind of resources you can get. But the Dementia Directive, I took a picture. That's why this slide is kind of skanky here, of the one I was working off of. And I apologize because the next few slides are kind of cluttered with a lot of information, but I wanted to have a document that you could pull together and you could work with your family and your doctor to say, look, if I should get dementia, this is a roadmap as to what I would want and don't want. If I'm not making sense and I'm not myself, I don't want certain things, and other things I do want. And And again, there's room at the end of this document to fill it out more thoroughly, and some of it's redundant with some of the other things you filled out. But I think it's important that this one states that it's just really about dementia. And I wouldn't even use Alzheimer's. I'd use dementia. There's different forms, and it can come on in different ways. But you want people to know what you would want. And I know it can be hard. You bring these things up and people are going, oh, no, we don't need to talk about that now. So, okay, so I think what I did in the beginning was we look at, if you live as long as possible, what do those three things mean when we answer the questions coming up? We want to live as long as possible, treat me, but not aggressively, or allow a natural death. And I kind of like that term, treat me, but not aggressively. So first we have live as long as possible. My goal is to live as long as possible, receive everything the hospitals can throw at me, that including 911, going to the hospital, feeding tube, everything. Treat me, but not as aggressively. I want to continue medication for chronic health conditions, heart disease, diabetes, treatment for illness, pneumonia or infections, which very often, but I don't think I want to go to surgery. Or I don't want long-term feeding tubes or anything aggressive or anything that would make me feel worse, like chemotherapy or something. But here you're kind of leaving it open to see what's there. And lastly, allow a natural death. Focus on comfort care, avoiding medication and treatments that would try and prolong life. And this could include stopping dialysis. I meet patients every month who've stopped dialysis and want to move forward with death. Blood transfusions, avoiding surgery, turning off a pacemaker, or withdrawing treatment for heart disease, diabetes, or other conditions. You all have a right at any time to make decisions like those about your treatment, your ongoing treatment. You can change it at any time. So if my physician or healthcare provider determine my dementia has progressed to advanced or late stage, then which of those things would you want? So now you've got like 2 pages of little boxes of what if. Take your time, sign and date your completed document. And if you sign it in front of a witness, I would have them sign it too. Share your document and discuss your wishes with your healthcare proxy and your doctor, and then save a copy with your existing Advance Directive. And again, if things change a great deal, you can redo this at any time, and or, like I said, I would sign it and say it's still how you feel. What if I require 24-hour assistance and supervision? You can't be left alone. What do you want to happen then? And I think when we think about that, treat me but not aggressively, do you want antibiotics and stuff for pneumonia? That's what I see sometimes. So you may want to be a little more specific about which medications you would or wouldn't want. If I no longer recognize my loved ones, I apologize, these slides are so crowded, but I wanted you to see what was on these forms so we can at least talk about them. If I'm unable to walk or move, if I'm unable to bathe or clean myself without assistance, if I'm unable to remain in my home and I have to live in a facility, you might want to specify something there. If I no longer have control of my bladder or my bowels, if I'm no longer aware of my surroundings, and if I'm unable to communicate my thoughts or my needs, and my phrases don't make sense. So I think these are very important to be able to discuss and to delineate what you're thinking and what you want. And then the top one's about hospice. If I'm interested in hospice care to support me and loved ones, I'd like to enroll as soon as I'm eligible. I'm not interested in hospice, or I'm unsure at this time. My surrogate can make a difference. Understand that hospice can last 6 months to a year. Every 6 months, they'll evaluate a patient and see if they've declined. And if they've declined in those 6 months, they can re-up them for another 6 months. They're a little tougher with they used to be. And of course, California's way tough right now with all the fraud they've been finding. But there are excellent, excellent hospices. And when you have a patient on hospice, medication is going to get delivered to the home. The nurse is going to visit at least once a week, usually more often than that, to check on the patient, see what else is needed for their care. Hospital beds can be there, and they can even send aides to help with bathing. So really, really think about using hospice if necessary. Food and drink, if I'm no longer appear to be, oh, I realize I didn't separate that. If I no longer appear to desire food and drink, turn my head away, or otherwise avoid being fed or giving fluids, I do not want to open my mouth or drink without prompting, and all food and drink must be provided by a caregiver. I'm unable to safely swallow, or the negative consequences of continued food or drink outweigh the benefits. Then I request all food and drink be stopped, including nutritional support and hydration. So I think the only other thing I'd mention there is, yes, this is possible. A lot of facilities will worry about, the patient will stop eating, but they still bring a tray in every time. You have a right not to eat. And then I think if a patient is hungry or is asking for something else, we can keep the mouth moisturized, make sure hands and feet are well moisturized, make sure that if they're asking for something, we give them something. But if they're unable to swallow food and they're choking, then if you've already said that you don't want a feeding tube, then make sure that, everything stops at that point. You want to be on hospice and have a comfortable, natural death. And lastly on this, it says, this document will guide my medical team and surrogate. I authorize them to be flexible and make decisions based on what they feel is in my best interest. Or this document should serve as clear and precise direction to my medical team. My wishes should be followed as much as possible, even if they would personally prefer another option. And that's a big point there. And we want to highlight that. If you feel very strongly about what you would want and wouldn't want if you have dementia, I would definitely make sure that you're marking that. Only one option, and that flexibility for your surrogate can be checked. Where is that one? And then I would be sure and make sure that you sign that. And this doesn't require notary, but again, if you feel like somebody might not believe the way you do, and again, I encourage you to discuss these with your family members. And if you think there could be an incident, then I can also get it notarized, okay? So what are we going to do with these? You have all this information. Some people actually do carry them around and have them, but now we have computers. You can make copies, scan them in, have them in your phone, or upload them. There's even a place in California where you can upload your Advance Directive in California, but definitely keep them digital or video, or have them available on your phone so if there is a question. Make copies, and all of these copies are as good as the real thing. Do not put it in a safe or in a safety deposit box, as no one's going to be able to get to it when you need it. If you do scan it And you don't need a scanner. There's little scan apps that you can get right for your phone. But there are services like Medical Alert and MAID Directives and the US Advanced Care Registry. You could upload them there. But I like to keep them where you can adjust them and add to them when you need to. And California has a directive registry. It's a California state sponsored site. And that link is at the very end. If you need it, what I'll probably do is send some of these links back to Rebecca and she can get them if you need them later on. But you can upload it there. So make sure you're specifying. The biggest things to specify in the dementia document is your feeling about food and fluid and infections and antibiotics. I think those are the few things that really have the most important in helping to help us with a more natural death. Communicate to the loved ones you would want and when. Discuss often. And you can always write a personal statement. It's just like the video that we talked about. So thank you. We did it. We got through them all. I know it's tedious. I know it's a lot, but I think having them and having things written down will also help for you to understand what it is that you want, but more importantly, help your family members understand what you want. And you will find that it will open up more discussions about your care and why you feel the way you do. Often when people haven't been ill too, I think they don't understand as easily as those that have been ill. So you may have to do a little education in the process.
Thank you, Karen. So we do have a couple of questions. For those, please feel free to put it into the chat and I can read them out loud to Karen. This is just a comment. I wish I heard this talk before I had to make a decision for my dad with the GI tube. It had huge implications. Yes, very important talk, Karen. Thank you so much. So excellent. Thank you so much for this. Yes, very valuable information. Thank you for preparing and presenting in an easy to understand format. Yes, absolutely. Question. So for these forms, can you upload it into your MyChart file or whatever medical provider file app that you use?
Yes, you should be able to do that. You can do that. Whether if you're having difficulty, you may have to ask a son or a grandson, but there should be a spot that says upload your advance directive. If not, copy it, make a copy, and then bring it with you the next time. I find a lot of people now are taking pictures with their phone, but there are free apps that say scan. There's one called Scan Genius, where you hold it over like you're taking a picture of something, and it actually is a scan of the document that you can email to yourself and then email to a doctor or your kids or a friend or something. So, but yes, make copies either with your phone or with a photocopy machine. And if you haven't been able to upload to your MyChart, just give it to the doctor's office the next time you go and they'll upload it. Let them do that work. But again, if you change it, don't think now it's done, I can't change it. If you decide to change something, bring them the new version the next time you come. And
wonderful.
And in terms of that POLST, I didn't like I say, it's bright pink, the original ones, and whatever it is, if you have been chronically ill or something ongoing, have it somewhere where it's easily to grab, or that your friends or neighbors or children know where it is in the house, should you have an emergency. And take it with you to the hospital if you go.
Thank you, Karen. Next question. What happens if there's a conflict between the Advance Directive and POLST form?
The POLST form, because it's signed by a physician, would probably be what they would follow. Yeah.
Thank you. So for the POLST form, if you no longer, when does it have to be updated? For example, if you no longer see the physician who signed it, do you have to get it re-signed again, or does that still stand?
No, I mean, I think by and by, I mean, even you're not seeing that physician, it was signed by a physician, as long as they're still legally in practice. Doesn't, when you saw that physician, this is what you two agreed on. So they're not going to ask if it's still your doctor or not. But again, it's the kind of thing if, you know, it doesn't say anywhere on there. We went through this once with another patient of how long it's good for. Because at any time you can void it, you know, just write void all over it. So you can, but you can also change it yourself if you want to at some point. Okay.
All right. And then for the POLST, how often do you recommend it to be updated or reviewed? Is it kind of like the Advance Directives almost?
Yeah, no, I would do it for a POLST. I would do more often, at least every 6 months. I would look at it and make sure that you know, you haven't changed anything, because it asks the date that the form was prepared, and depends on how your form is. If you have 2 sides to a pink one, you can always at the bottom you know, re-sign it. They really haven't changed the forms much in the last few years, but you can always sign it again and redate it. Like I say, even attach a note if things haven't changed significantly. If you haven't changed those full ideas of full, selective, or comfort focus, or made the changes. So.
Thank you, Karen. Next question. Is there somewhere that we can read more about possible things that could happen in an emergency room that I can consider specifics to include in the Advance Directive?
No, that's a good question. I think it's
Yeah.
such a individual thing. I was thinking, no, you just have to sit around and watch The Pit or Grey's Anatomy or something. I mean, like, that's everything you see happening on those programs. And people come to groups all the time, ask me, well, you know what I saw? And then we think that will happen. I think, you know, it's a good conversation to have with your doctor. It's like, what are some of the things I can expect to happen? Because all of us are different, and what are the chronic issues you're experiencing, whether it's high blood pressure and we want to worry about a stroke or diabetes, or I think knowing and understanding your body and some of the issues you've been dealing with, I think that's what you want to look towards. But you know, anything can happen at any time. I think that's it. In terms of what can happen in an ER and what can go wrong, you know, most times you're in the ER, you're sitting around, you're waiting to be taken care of. It's when the patient can't speak for themselves and we lose, you know, vital signs, breathing and cardiac, that things step in, and then we're trying to resuscitate that patient. So basically, if you're at the point where you don't want to be resuscitated, you don't want to wake up with a tube in your throat, then you have to make sure that that's spelled out. And I think that's the big part of what can happen in the ER. I don't think there's anything else that's going to happen that you're not going to be aware of. You know, we fall, you know, the other big thing in elderly is falling. Someone's broken a hip or broken a bone, and you know, that's a whole another scenario, because depending on what it is, how we're going to get cared for, whether we're going to end up in the hospital or assisted living facility, and then that's a little bit of a longer chronic illness that you're dealing with. And then you have all those other side issues to think about in terms of infections and, you know, nutrition and things like that. But there are, you can work with a patient advocate, and a lot of big facilities have patient advocates and social workers. A lot of the big institutions will have those, and they can really be a good service to help you understand what's possible and what isn't through these documents.
Wonderful. Thank you. Next question. Would you recommend a medical alert bracelet?
Yeah, I think there are a lot of places that will look, especially if you're diabetic or you have a pacemaker, or you have, those are pretty easy to find on someone. But if there are, yeah, I mean, they will look for them and try and understand why someone is unconscious. And I think you can register them too somewhere.
Thank you. If there are any other questions, please feel free to put it into the chat and I can read them out loud. And just another reminder that this workshop was recorded, but the first workshop, more about talking about end-of-life options, the overview, that was also recorded. So you can find that in your Sunday. Every Sunday morning, you should get an email from us about different programs coming up. So if you scroll to the bottom where it says recent workshop recordings, you'll find a link to both of these workshop recordings. Thank you so much, Karen, for your time and expertise and just compassion. Such an important topic, and I'm so glad that we're talking about that today.
Thank you. Thank you for offering it, and thank you for being here today. I appreciate you too and all that you're doing there.